I am going to describe the procedure and important information regarding an exploratory laparotomy. The word laparotomy is derived from the Greek words lapara, meaning flank, and tomi, meaning cut. In surgical practice, this translates to a big cut in the abdomen to gain access to the peritoneal cavity. By definition, an exploratory laparotomy is performed with the objective of obtaining information that is not available via clinical diagnostic methods. It is usually performed in patients with acute or unexplained abdominal pain, in patients who have sustained abdominal trauma, and occasionally for staging in patients with a malignancy. Organs that may be examined during an exploratory laparotomy include the liver, gallbladder, spleen, pancreas, kidneys, stomach, small intestine or small bowel, large intestine or colon and large bowel, appendix, ovaries, fallopian tubes, uterus, lymph nodes, abdominal blood vessels, and membranes that line the abdominal cavity. Instruments used for this procedure include curved hemostats, Kelly forceps, Alice forceps, number 3 knife handle, Matson straight Mayo scissors, DeBakey's, tooth forceps, Adson forceps, Bookwalter, Army Navy, and Richardson retractors. Suctioning includes Yonkauer and Poole, Mayo Hagar needle holders, and skin stapler. Surgical equipment needed for the case would be sequential compression devices with disposable leg wraps, forced air warming blanket / mattress pad or the bear hugger, suction, ESU, a regular OR bed, head in normal position, anesthesia equipment, and theater lighting. Room setup for an XLAP uses a regular surgical table and is typically located in the center of the room, centered under the center of the boom arm of the lights. An anesthesia machine is located at the head of the patient. There's a Mayo stand and a back table that will be next to the Mayo stand, and a suction or Neptune machine. The back table setup consists of the irrigation, laps, various vessels for liquids and medications, towels, suture and needle holder, blade, knife handle, sharps holder, bandage scissors, timeout sign, and the instrumentation set. The Mayo setup includes the light handles and ESP and Bovie tips, as well as the items needed for the beginning of the surgery. Exploratory laparotomy is performed with the patient under general anesthesia, which is medicine that is used to put you in a state like deep sleep during surgery. The medicine may be inhaled through a breathing mask or tube, or it may be given through an IV. A breathing tube may be inserted into your windpipe. This is to help you breathe during surgery. The two major pre-anesthetic medications used in patients undergoing exploratory laparotomy include ondansetron and tramadol. There are 4 phases of intraoperative general anesthesia: induction, maintenance, emergence, and recovery. 1% lidocaine is often used as a localized anesthetic. The patient is placed in the supine position with the arms abducted at right angles to the body. Determine the intended site of incision. Begin at this clean site working outward. Prep sponges are used only once, as the same sponge is never used to go back over an area. Instead, a new sponge is taken. Cleansing is done on the skin surface area from nipples to mid-thigh level and down to the table at the side. An exploratory laparotomy is a surgical procedure in which a large incision is made at the abdomen to allow the surgeon to examine the organs and tissues inside. The midline incision is the most common. During this procedure, the surgeon will use various instruments to dissect and retract tissue, identify any problem areas, and resolve any issues found. The incision is then closed in. Step 1. Making the incision. To begin the surgery, the surgeon will use a 10 blade to make a large incision in the patient's abdomen. Once the incision is made, the surgeon will use cautery, met scissors, and the variety of pickups to dissect down to the bowel. Step 2. Retracting and dissecting. At the beginning of the surgery, the surgeon will use medium and big Richardson retractors to retract the area. Once the area is retracted, the surgeon will use their hands to follow the intestines to locate the problem area. They will use a combination of pickups and cautery to dissect through the tissue as necessary. Step 3. Identifying and resolving the issue. The surgeon will try to find the problem area, which may be a twisted piece of intestine that needs to be repositioned or a dead part of the bowel that requires resection. In rare cases, the surgeon may not be able to find any issues with the abdomen. Once the problem is identified, the surgeon will resolve it. In this case, dilated ischemic small bowel loops. Once the procedure is completed, the abdominal wall is closed. Before closure, the instrument and pad counts must be double-checked. The surgeon should manually inspect the peritoneum for any retained pads or instruments, even if the surgical technologist has found the count to be correct. Step 4. Closing the incision. After resolving the issue, the abdomen is usually closed in layers and a drain may be placed to prevent any excessive fluid and pooling in the abdomen. If the patient is expected to have another surgery or if there is significant amount of infection, the abdomen may be left open. This conventional gauze or 4x4s are used upon skin closure with a bandage, skin strips, and tapes. The skin may also be closed using Dermabond, a skin sealant, and sometimes no dressing at all is used to allow for open wound healing. Another satisfied customer. Let's hope the following complications don't happen to him: painful swelling, increasing redness around the incision, copious or thick drainage from the incision. He should avoid heavy lifting of more than 10 to 15 pounds or abdominal straining for 6 weeks. Fatigue is common when you go home. Walking and going up and down stairs is fine, but no strenuous activity for 4 to 6 weeks.